Welcome, everybody. If you're here for the Menopause webinar, you are in the right place. We're excited to be here with you tonight, and we would like to start with our land acknowledgement. So Lifemark Health Group acknowledges that our work spans many territories and treaty areas, and that we're grateful for the traditional knowledge keepers and elders who are here with us today, those who have gone before us, and the youth that inspire us. Thank you so much, everybody. My name's Andrea Kay. I'm excited to be here with you tonight. I'm a physiotherapist and I work for Lifemark, but I'm not here as a physio. I'm here as someone who really wants to understand this information better. This is very pertinent and with my age and in my type and time of lifetime to critically understand what's going on. Also know how I can better navigate what's about to come. Last March, we had a somewhat similar webinar. March, we try to help celebrate International Women's Day, so we bring things that we think are very important for women. And the one that we hosted was called, Is Your Pelvic Floor Trying to Tell You Something? If you would like to find that, you can go to lifemark.ca and you can search for that. But after the webinar, we asked for feedback, as we do. And you said you wanted more. So we're back here by popular demand. And today our goal is to debunk the myths that are around perimenopause and menopause. So we couldn't be here today without, of course, being supported by Lifemark for this occasion. And if you don't know about Lifemark, Lifemark is Canada's largest physiotherapy company. We are coast to coast with over 320 clinics and 2,500 clinicians. And we're all passionate about enriching the health and lives of Canadians. We're also here in partnership with the PC Health and the PC Health app. I'm going to share more about that and the resources available through the PC Health app after we hear from our presenters. So you might be thinking things are looking a little bit odd. I don't really know what I'm seeing right now because we're using something called Zoom webinars. So if you're used to Zoom meetings, you'd be like, I can't mute, I can't turn my camera on. That's okay, that's normal. But what we do want to draw your attention to is it should be somewhere on the bottom toolbar. So if you scroll your cursor at the bottom of your screen, you'll see something called Q&A. So that's the question and answer box. We're going to be answering questions there, and we welcome your questions. So please put them into the box. But remember, we can't give you any personalized advice, right? We need to know and understand a whole bunch more that we can give you personal advice on. And it's important that you don't share your personal history in that chat. But we have people who will be answering. We do hope that we're going to share a lot of information with you tonight, but don't worry, you don't need to be taking notes. This is being recorded and you will all be getting a copy of the recording as well as some feedback that should be arriving in your inboxes in the next week or so. So keep an eye out for that. You also can change your view to speaker mode. So that's often up in the top right-hand corner. And if you can change it to speaker mode, then you should just see the slide as well as who's actually speaking. So that can make it maybe a little bit a better experience for you. Our panelists today are physiotherapists, and to know that they are bound by scope of practice. So we won't be answering any questions about medication management, medication assistance, any reconciliation, or medication advice. So we wanted to make sure that you were aware of that. Now, before we go and introduce and meet our panelists for tonight, it's important that we want to acknowledge that not all individuals born with female anatomy identify as women. Today's discussion, we are going to be referring to female anatomy. So let's jump in and meet our presenters. Alana-Devlin obtained her Bachelor of Medical Rehabilitation in Physiotherapy from the University of Manitoba in 1996. She became a certified manipulative therapist in 2002 and began to pursue further advanced education in her passion for women's health. She's engaged in advanced training throughout Canada and the US, and in 2018 and 19, she successfully obtained a certification of achievement in pregnancy, postpartum physical therapy, and the Certificate of Achievement in Pelvic Physical Therapy through the American Physical Therapy Association. She also completed her doctoral degree in physiotherapy in the summer of 2021. She's proud to be an instructor and teaching assistant and work alongside gynecology and urogynecology health professionals. She serves on the board of the Canadian Society of Pelvic Medicine, as well as being a member of the Canadian Menopause Society. Alana works out of Lifemark ProChild Twin Arenas in Northwest Calgary. Now, Uma graduated from the University of Toronto with a Bachelor of Science in Physical Therapy in 2003 and completed a Doctor of Physical Therapy at Boston University in 2010. She began treating clients with pelvic floor dysfunction secondary to cancer intervention while working in New York at Memorial Sloan Kettering Cancer Center. Since coming back to Toronto, Uma has dedicated her efforts to treating women and men with pelvic floor dysfunction. She currently practices at Lifemark Leslie and Shepherd in North York and coordinates the pelvic health curriculum as an adjunct lecturer for the University of Toronto Physical Therapy Department. We've gone to find you the best of the best to give you as much information as we can. So we're really honored to have you, Alana and Uma, here to share your information. I'd like to just take a moment and acknowledge the folks that are going to be in the chat. So it's not the chat, the Q&A. They will be answering your questions in the Q&A. So thank you so much to Susie Smith, Nimi Thomas, and Karen Transgruden for their fast fingers who will be busy answering those questions for you. As we said, we want to make sure that we're looking at kind of these common questions. And when we hear about menopause, we are hearing a lot about menopause and perimenopause these days, which is great. We want to talk about it more. You know, it's been a taboo subject that, you know, it feels like we were in the dark ages only a few years ago. But, you know, we want to get a good start and start with the obvious. Myth number one: I've missed a few periods. This means I'm in menopause, right? Alana, can you talk to us about like what is menopause and perimenopause and how do we know we're in it?
Yeah, sometimes it seems like it should be a really easy question to answer, and sometimes it's not. So, first of all, the first thing to know is women don't age in a linear fashion like men do. We kind of have these rapid fluctuations and these rises and falls. And we actually think it's the rapid rises and falls that are giving people a lot of the symptoms. So, it's the exact same hormones that rise to put us through puberty are the things that start to decline that put us into perimenopause. So the first thing is also this is a natural transitional stage of midlife. It is not a disease. But just like anything else, if we understand why we're having those changes, which is really what we're trying to do tonight, then we can be empowered to know what to do to help with them and kind of to know what to do to address the problems and who to approach with it. So women don't have to suffer through things like we've kind of been conditioned to. We really can be empowered that we know, what to do, and there are resources out there. So, the quintessential definition of perimenopause, honestly, is unpredictability. And that is why it is so frustrating to deal with. So, we no longer have these predictable cycles. And so we don't have these beautiful ebbs and flows every month that are so predictable. We can have one month that's very erratic. The next month is more of an ebb and flow. The next month is maybe half erratic and half of an ebb and flow. So it really is unpredictable. And that's why so many healthcare providers who are menopause informed won't even ask you to do blood tests to see where you are in your cycle, because we know that during this time, we don't know where you are in your cycle truly. So it's really where we want to listen to your symptoms. And that's where it's important to know what the symptoms are so you know how to approach your healthcare provider with some of those. So we know that surprisingly, some women can actually go through and start to experience these symptoms in their late 30s. This is when kind of estrogen really, the level kind of just begins to decline or decrease. And this change can span a decade. So It's not just a short time. And it's really how we like to think about it is perimenopause. It's kind of broken into earlier perimenopausal stages and later perimenopausal stages. So in early perimenopause, there actually may not be any changes to your menstrual cycle. You may be getting regular cycling, but that doesn't mean you can't start to experience symptoms. Like you maybe start to experience sleep issues or night sweats or heavier menstrual bleeding, or maybe find you can't tolerate exercise as well. Like I used to do a lot better and more, and I used to recover easier, and you just can't. You don't have that same capacity. And then later on, as hormones start to decline and progress even further, maybe you start having irregular cycles. Maybe they're longer cycles or shorter cycles. And you can see the cycle, kind of the pattern change by up to 7 days longer or shorter. And so then later on in menopause, that's where we're skipping months, like we're skipping cycles. And so you can have even, you might have a skipped cycle of 60 days, and then you might have a 30-day cycle, and then you can have a 90-day cycle. It's again, it's very erratic. And this will progress. And this is when symptoms usually start to kind of increase too for many women, until the time of 1 full year where you do not have any cycling, you do not have any bleeds for 1 full year. And this is officially when menopause, you can say that now you are menopausal. So the definition of menopause really is when a woman's ovaries stop producing enough estrogen and progesterone that it's not enough for them to actually produce an egg. So this usually occurs when we know for sure that you have not had that period for 1 full year. I just want to also say in perimenopause, people can still get pregnant. So we don't know, again, when you're ovulating and when that cycle happens. So just wanted to add that. Some people also go through this whole change experiencing absolutely no symptoms, and aren't they lucky? And some people have really severe symptoms. So you don't want to compare yourself to others or judge people on, thinking about, well, geez, mine wasn't that bad, because it really is individual. And we're going to talk about that word individual a lot today. So some people think that because they didn't have any symptoms at all, they didn't go through menopause. But even if you have no symptoms, these metabolic changes are happening. So the other thing to talk about is it's really hard if we're looking for that change in your cycle. It's not as easy for some people. If you have an IUD in place that's really changing your cyclic patterns, you have to know your symptoms, and we want to listen to your symptoms. If you have had a surgery where you've had a hysterectomy and your ovaries have been removed, that's going to put you into immediate menopause. If you've had a hysterectomy where they've preserved your ovaries are still there, we know that woman will go into menopause about 1.9 years earlier than if they hadn't had that surgery altogether. And then the other thing is sometimes people are put into medical menopause, and that's where they're given, whether it's radiation or chemotherapy for treatments that have to do with some gynecological cancers. And that may put you into more of a temporary menopause or a permanent menopause. So those people don't have that clear signal of a lost period. So it's really important that they find a provider that's going to listen to their symptoms, that they know what their symptoms are. And the thing is, we use the word post-menopause a lot, but there really is no post-menopause. You go through menopause, and this is your new phase that you're in, and it's lasting anywhere from a third to a quarter of a woman's life. So we need to know what to do during these times. It's important.
Thank you. I think that really will get us kind of on a level set, speaking the same common language and really just understanding the basics of timelines, which we just heard, there is no timelines and nobody's on a calendar. It's extremely unpredictable. So if you feel like things are unpredictable in your life, it might be just a sign that you are in this perimenopause phase. Now, myth number 2, I don't have any hot flashes. I'm not in menopause, right? So let's dive into, some of the effects and changes that can occur. Alana's just told us that, you might not feel anything, but that doesn't mean changes aren't happening subtly or internally that you're not aware of. Please help us understand some of these systemic changes that we're going to see with that decreased estrogen, Uma.
For sure. So I think before we get into all of these things, I think there's one thing that's worth repeating that Alana just said, which is that perimenopause can span over the course of an entire decade. And so if there are individuals who are going into menopause in their late 40s, early 50s, that means that they're starting some of their symptoms in the late 30s and early 40s. And so this happens to coincide with childbearing years for certain people. And they can have some individuals going from postpartum to perimenopause. And so both of these states are estrogen depleted states. And so if symptoms that you're having in the postpartum phase aren't necessarily changing, that's something that we want to kind of keep in the back of our minds, because that is, I'm sure there's a lot of people in the audience that applies to. So I just wanted to point out, and again into the actual symptoms of perimenopause. There are the obvious ones that we all know about: the hot flashes, the mood swings, the irritability, and then the ones that are easier to pick up on, that Alana's already kind of gone through, which is changes in the menstrual cycle. And those are easier to pick up on, of course, because we have our cycle pretty much every month, and every time there's something subtle that changes, but it's changing that we're experiencing some of those changes, something that happens so frequently, you tend to pick up on it a little bit more quickly, right? So some people will have regular cycles that all of a sudden become irregular. Some people have irregular cycles that all of a sudden you're banging out these eggs like they're going out of style. Some people will have heavier bleeding. Some people have lighter bleeding. Some people might notice that they're not ovulating every cycle because they have significant PMS symptoms that they're not necessarily having every single cycle. So you can pick up on the cycles that you're actually ovulating and some that you're actually not. So those are more easier to pick up on. And then there's some sneaky little symptoms that we may not really realize that actually even have anything to do with perimenopause, like things like heart palpitations and hair loss and changes in your body odor, fatigue levels and energy levels, vaginal dryness issues that may not necessarily be out there throughout the entirety of the cycle, but maybe just after you've finished your period or just after ovulation, and just kind of creeping into different parts of your cycle. So there's a lot of different things on that list. And like I think I saw somewhere on Google, it was like a list of 50 symptoms. And so if you're experiencing some of these things, you're not going crazy. It's actually something that's happening. It's a thing. And it's important to recognize that there are some symptoms that we don't necessarily know or talk about or even recognize as being part of perimenopause. Now, it's really important for us to understand the actual systemic changes and the reason why these things are happening. So if you look on the next slide here, the big player is estrogen. And in a female human body, estrogen literally regulates every single thing that you can possibly think of. So if it regulates multiple systems, then we're going to notice some changes in many of these systems. And so I'm going to kind of go through each one of these symptoms to talk about what the symptoms are. Now, as far as cardiovascular health, estrogen is hugely important for the metabolization of cholesterol. And so when that starts to deplete, we are going to have an increase in chances of arterial disease and risk of cardiovascular events like stroke and heart attack. And so this is the #1 risk for women in the menopausal years. And estrogen also has a role to play in the nervous system and neurological functioning. So that's where all of our brain fog and our cognitive functioning, attention span, memory, all of that kind of stuff, those symptoms start to creep in too. Estrogen, of course, is a hormone, and surprise, surprise, it also regulates other hormones in our body, specifically stress hormones like cortisol and adrenaline. And so this is a time period that you might start to feel a bit more anxiety or start to feel more overwhelmed by things that maybe we would have had much better coping mechanisms around in previous years. Estrogen also regulates our immune system as well as the thyroid system. And so during this time, we start to maybe experience some fluctuations in thyroid functioning, either hyper or hypo. In terms of digestion, estrogen also can cause a slowing down of motility, leading into constipation symptoms. And when it comes to pelvic health, constipation is your #1 enemy. So it's so important that we try to keep on top of our hydration and our fiber intake, and really try to keep on top of dietary proper diets. This can also lead to body composition changes. So a lot of us might start to notice that we're starting to have a little bit more girth in our midsection, and or possibly the number on the scale isn't really necessarily changing, but the clothes are definitely fitting a little bit differently now too. And so this is also something that we will start to experience in these perimenopausal years as well. Now, on our next slide, as far as physiotherapists, where physiotherapists go, this is kind of our jam. When it comes to the musculoskeletal system, this is where we really can make an impact. But the changes to the musculoskeletal system is such that estrogen is hugely important for lean muscle mass and for tendons and ligaments and the health of those ligaments. And so what changes happen to the musculoskeletal system is that when we lose lean muscle mass, muscles are no longer able to generate as much power or maintain as much endurance with these changes. And when these muscles are attached to tendons that now become a little bit more stiff and a little bit more resistant to stretch, this can put us at risk of having some injuries to muscles, specifically the ones that span over joints that move in large ranges of motion, like your shoulders and like your hips. So all of those frozen shoulders that start to come up in our 40s and 50s and 60s, that's a huge reason why, because these muscles and ligaments are just not able to tolerate load the same way that they would have been before. As far as sexual health goes, obviously the two are huge estrogen-rich environments, and so the vaginal dryness and some of the loss of moisture can lead to discomfort and loss of libido and desire. And finally, with our emotional and mental health, we've already kind of touched upon some of these other issues with anxiety and stress and depression. But if we add sleep disturbance into that mix, we can all agree that a night after not sleeping well is not a great day that follows the physical months and potentially years. This is going to compound all of the mental health and cognitive functioning issues like the brain fog and the memory issues that come along with the state of life. So I know this sounds like a lot of gloom and doom. It's a very, very dire list. However, it's really important for us to understand that estrogen plays a role in all of these symptoms, and recognizing some of these symptoms is also hugely important. But what we really want to impart is that not everybody is going to get everything. Some people are, like Alana said, going to have huge symptoms and really significant symptoms, and there's going to be those magical people who their periods stop one magical day and they just ride off into the sunset like nothing ever even happened. So that's going to happen too. But the purpose of our talk today is to empower you with what you can do to help this transition over. And so what we're going to get into in the rest of the talk hopefully will take away some of the gloom and doom of what I just talked about here right now.
Absolutely. And thanks, Uma. I think it's great to know that. It is a little bit daunting when you think about all the different changes, but without education, we don't know how to move forward. And as you said, we really want to look at what are the things that we can do. And I've already seen some of these questions in the Q&A, but thinking about that battle of the bulge phase, we hear you need to exercise or exercise more. And so that brings us to myth number 3. I shouldn't do heavier intense exercises as I get older because it's easier to get hurt. We've heard about the changes that happen in our musculoskeletal system. And, I think that's often a general myth, fortunately, about even aging is what's going to happen and what to actually do as we get older. So Alana, if you could please walk us through or maybe run us through some of the details about what the research shows about how we should be exercising as we age and getting into this perimenopause and menopause phase.
So first of all, you can walk or run. It's whatever brings you joy. You do whatever you enjoy doing, and you can level this up or down, because at first when I talk about this, it sounds like you have to be an Olympic athlete, and you absolutely do not. So you can really scale this to everything. So as we've said, perimenopause and menopause does bring a lot of changes, and some you expect. It's like the hot flashes and the difficulty sleeping, the irregular periods that we all know about, but a lot are a bit sneakier. And a lot of these changes actually we know now happen 3 or 4 years before menopause. So this is really when you want to start paying attention to it if you're in that phase. But if you're past that phase, it's never too late either. So it's not on a basic timeline. But what we know now is that if you can pay attention to it earlier, this is when those changes happen. So we know that muscle mass actually naturally declines, if I can talk, between 3 to 8% per decade after the age of 30. And then that tends to speed up during those menopausal years. We know that, again, we've talked about this, that body fat tends to increase, especially around that midsection. And it's not just kind of the fat underneath your skin that we worry about so much. It's actually the fat that's hidden between all of your organs. We call it visceral fat. So we actually even know that there are some people who seem very thin on the outside. If they have increased visceral fat, they're actually at a higher risk for cardiovascular disease than if somebody is a little bit more round. So it does not, again, this has nothing to do with the numbers on the scale or the way your body presents. So bone density is also a big thing, and that starts to drop, especially in those first 5 years of menopause. Women can lose about 10% of their bone mass in that first 5 years. And as we've all known, many women who've had increased risk of fractures, this is a big problem. So I know this may sound a little bit depressing and we haven't gotten to the good stuff yet, but the good stuff is there is so much you can do. Like, we really are empowered and we have so much power to fight back and compensate for these changes. So if we understand the changes again and we have the right kind of exercise, we can really fight back hard. So the issue is traditionally how we've been told to exercise might not really be adequate for this time. And it's not great for improving during this time our bone health or that muscle maintenance or those body composition changes we're talking about. So often women feel that they've really tried the same techniques. They're going to try and exercise the way they have for years. You know, I've wanted to lose weight, so I'm going to try running again. And I'm going to try we've always been taught to do a lot of cardio, and cardio is excellent, but sometimes it's not doing what we need it to do when people are really trying to lose weight or change their body composition in this stage of life. So that's the biggest thing. And then the next thing is we all then just start eating less. And you have a lot of women that are so frustrated because they're barely eating anything and they just have no control over these weight changes. So it's really, really tough. So we do know that there's tons of stuff you can do. And let me explain why. So first of all, we know that a lot of these changes are related to the drop in estrogen, and especially, again, how your body stores fat and how your body builds and maintains muscle. So you become much less efficient at using protein to grow muscle and to repair muscle. And that's why when we're losing our estrogen, we now know, when I went to school, we thought, oh, these women, they don't need to eat that much protein. Now we know women in this stage, in our age, really do need to eat far more protein than we ever thought. So don't forget, estrogen is a steroid. That's our steroid hormone. So this is really important in lean muscle mass and also in lean muscle mass recovery. So your bones, they need stimulation by impact and also resistance exercises to stay strong. So if you're doing the same 30-minute walk or, 15-minute jog that you have for years, again, this just may not be optimal for these. If you still enjoy that walk and jog, don't stop, because they're still great for a lot of other reasons. So what do we need to change? Like, where is the research at showing us what we need to change? So one is, we say we need to do heavy resistance training. When I say heavy resistance training, it is heavy for you. It's not heavy for everybody else. So it's really important to individualize. Heavy for some people, maybe just getting in and out of a chair a few times. For another person, that might be doing a squat with 125 pounds on their back. So it's really important to understand this must be individualized. So this can be lifting weights. It can be using resistant bands. It can be using just body weight exercises like squats or push-ups or lunges. There's a ton of different options. And the difference really is, again, that in this stage, we really want things to be fairly difficult for you. So that means you want to have a 6 to 8, we call it rep maximum ish. Like after 6 or 8 repetitions of a certain activity, you should kind of be happy that you're almost close to the end. But I also don't want you to lose form, because if you're losing form, then you're more apt to have injury. So this is really when sometimes it's really a great time to contact a physiotherapist you trust, contact a personal trainer, a kinesiologist you trust, really to discuss with you, maybe find what that 6 to 8 is for you, and make sure that you're using the proper form so you don't risk injury, because that's the last thing you want to do. The next thing on the list is, it's called some people have always asked questions already, HIIT training, or it's high intensity interval training. So really what this is it's short bursts of intense effort followed by a recovery period. So an example is, maybe you want to be at a 8 or 9 out of 10 effort. So you are working hard. This is not that easy. And again, it's an 8 or 9 out of 10 effort for you, not for whoever else is in the room. So you want to do that for about 20 seconds. And that can be done by walking, sprinting, cycling, swimming, body weight exercises. If you like burpees, I sure as hell don't, but if somebody else does, that's great. Whatever somebody enjoys doing. So you do that as hard as you possibly can for about 20 seconds. And then you have a minute or 90 seconds, sorry, to about a 2-minute recovery. So that is HIIT, we know now, is probably one of the best exercises we can possibly do, and the most effective ways that we can have to change that body composition in the midlife. And the reason why is that during menopause, we know that estrogen, again, and progesterone start to decline, but cortisol, so we've all maybe heard of cortisol. Cortisol is your stress hormone. So we know without, especially the estrogen, cortisol kind of doesn't have a way to kind of calm itself down. So this is where sometimes as your cortisol is creeping up, we don't want to do persistent high stress exercise that might spike your cortisol more. So that's why with HIIT training, it's great because it's like you're doing it's hard, but then you're allowing recovery. So they're finding you don't have those big cortisol spikes, which are causing problems, because we know that elevated cortisol may contribute to the belly fat and then the sleep disturbances and muscle breakdown, and also interfere with bone health, which is all the stuff we're trying to really stop. So although again, exercise again is a form of stress, if it's done correctly, if we're doing HIIT, you are allowing for that recovery. So we're not getting those cortisol spikes. So that's probably one of the best things we know that we can do. So research is really showing us it's 2 to 3 sessions, and they can be short workouts. This does not have to be, they're not hour-long classes that have arbitrarily been designed. It's like these are short workouts, and they can lead to huge changes in body composition and overall fitness. So we're finding it's 20 to 30 seconds on at 9 out of 10 power, 8 to 9 out of 10 power, with a 90-second recovery to 2 minutes. If you repeat that 5 to 8 times, you're done in 12 to 20 minutes. Good enough. Like that's all you really need. The third one we know is it's called plyometric training. So this is like a power training or jump training. And I know this sounds really intense, so just bear with me here, but it is a type of exercise that it involves a quick and explosive power movement. So for muscles, it's really important because we know that you have different types of muscle fibers, but explosive movements call on what's called a fast twitch fiber. So it's the kind of fiber that they're responsible for that strength, the speed, the power. And these fibers we know are the first type of muscle fibers to decline with age, unless we are actively training them. So we can use these type of exercises to stimulate this type of muscle fiber so we don't lose them. The other thing it's really great for is bone density. So bone is a living tissue, and it really responds to stress. It needs the right type of stress to kind of to grow and to thrive. So when you jump and you land with force, your bone experiences a brief high impact load. And that's kind of a signal to your body to say, hey, keep building more of me because I need you. So, and don't worry, I'm not talking about doing crazy box jumps at a gym. Again, if that's what you do, then amazing, you're tackling this. But for a lot of people, that is not approachable right now. So a box jump at a gym is great, but we can do something far, far easier. So you can start with just a low impact or modified version of a little mini jump. Like maybe you're just trying to kind of do a jump and you're holding on to something for balance, or you're just lifting your heels up quickly and like a powerful heel lift and then trying to come down with a small land. Jumping jacks are great. I don't know if a lot of people love that either, or even the low impact version is great. Skipping, hopping side to side, explosive squats. Explosive squats are when you squat down and then you come back up with an explosion almost, and you can go onto your toes or you can go jump onto your jump. You can add a little jump if you want. So those are great. If jumping isn't safe for you because you have joint problems, so let's say you have pelvic floor concerns, you can simulate these in other ways as well. Like you can just rise up onto your toes really quickly and you can kind of drop quickly onto your heels, or you can stomp around even. It makes a big difference because that's that impact. So again, we know just 5 to 10 minutes of these twice a week make a huge difference. They had a study published in the Journal of Bone and Mineral Research that found that 10 jumps twice a day over 6 months improved hip bone density in perimenopausal women. So that's just 20 jumps a day. And remember, you don't even have to leave the ground. These don't have to be huge jumps. So the most important part of any exercise is have fun, stay social. If you can, keep it moving. And we need to think about challenging our muscles and bones kind of in a new way as we age. We're not working harder or longer. We just have to work a bit smarter for where we're at.
Fantastic. I think that's really helpful to kind of hone in, like exercise more. That doesn't help us really understand. And what I'm hearing is you actually don't have to exercise more. You can exercise less if it's more intentful. So thanks so much for that specificity. That's really, really a good key take-home message for me. Now, we're talking to some amazing ladies who know and understand pelvic health. So let's get into our myth number 4. Is having a leaky bladder an inevitable part of menopause? I've already seen some of these in the Q&A, and you know, fortunately, it is a myth. But Uma, please help us understand what. Okay, so if it's a myth, what's the reality here for us?
Yes, absolutely. So the short answer is that no, we should not be experiencing leaky bladders just because we're going into this phase of life. But before we get into that, it's really important for us to actually talk about the pelvic floor and what it entails exactly. So if we look at this picture here on the left, this is a front view onto the pelvis, and the picture on the right is more of a bird's eye view looking down into the pelvic wall. The first thing I want to point out about the anatomy of the pelvis is that this structure is exceptionally strong. It is very structurally sound because we don't want to keep the elements of the human race in a house that's easy to break. So this is about the strongest structure that we actually have in our bodies. The other thing that I want to point out about the pelvic girdle is that the joints of the pelvic girdle do not move. This is a very stable structure, right? So if we look at the orientation of these muscles, they attach from front to back, side to side, and they are oriented kind of like a sling, or more importantly, like a trampoline. A trampoline is probably a better analogy to describe how these muscles work. These muscles actually have 4 major functions, which is bowel and bladder control. They are part of sexual functioning. They are part of the core and what stabilizes the core, and we'll talk about that in a second too. And they also play a role in circulation as part of the lymphatic system. So obviously, the changes that we've already talked about that happen to muscles with the loss of muscle mass, with the loss of ability to generate power, with the loss of being able to maintain endurance. If we think about a trampoline and how a trampoline actually works, a trampoline works in a bit of a reactionary type of method, right? So if we're kind of bouncing very gently on a trampoline, the excursion of that trampoline is going to be relatively small. But if you really ramp up and jump hard on a trampoline and power up, the trampoline is going to adapt to that load and demand by stretching a much bigger excursion and powering back up again. So when we take all the changes that happen, essentially what can happen to your trampoline is that it can overly be accommodating. So when you jump on it, it doesn't have the power to propel back up again. Or if you have a trampoline that has lost its ability to be stretchy, and now we've wound it up and made it really short and tight, and you jump on that trampoline, you're either going to break your legs or you're going to rip a hole right through it. And so these are kind of the presentations that can kind of occur with the pelvic floor musculature in this phase of life. And we can't really tell from looking on the outside what presentation you're actually going to end up with. So now to talk about the core, the true core, excuse me, this is important to talk about because everyone has heard at the gym, turn on your core, turn on your abs, brace your core, and all of us kind of suck in our stomach muscles when we hear that cue. The problem is that those six-pack muscles that we're turning on with that cue actually have absolutely nothing to do with the core. The true core is actually bordered at the top by the diaphragm, which is our main breathing muscle. And as human beings, there is nothing more basic we need to be able to do than to breathe. That is just basic primal need. So obviously that muscle is very important. On the other end of the core is our pelvic floor. And you can see here in this diagram that the pelvic floor is a mirror image of the diaphragm. So the diaphragm's kind of like an umbrella up the top, and then we've got our trampoline at the bottom. Now, in between those borders is not an empty canister the way that it kind of looks on this depiction. Oh, the animation's working. That's exciting. Okay, so you can see that everything's kind of moving up and down. Now, just in case that animation wasn't working, I put together this balloon. I don't know if you can see it very well, and pink, of course, to show what it actually kind of looks like. Sorry, I've got my orientation backwards here. There we go. Over here, over here. Okay, perfect. So the diaphragm would be at the top, core would be at the bottom, and you can see here as everything is moving down. I'm just going to use the orientation because I think it's a little confusing right now. So as the diaphragm is coming down, that's on an inhale. It's going to compress our balloon because that's all of our internal organs, and those organs are floating around like amoebas and plasma. They're shoved in there really, really tight. So that's why it's a balloon that's fully inflated and under pressure. So you're compressing a balloon from the top that's already full. Naturally, it will increase the pressure in that balloon. And that canister is kind of pulled in tight from the side. So the only way that that pressure can actually make its way through the system is to go down and out on the other end. As that pressure comes down, it's going to land on our trampoline. And so again, just like how I talked about with the different types of load that's going down on our trampoline, if we're just quietly breathing, the load transmission to the trampoline is small, so the excursion will be small. But let's say if you're coughing or laughing or sneezing or yelling at your kids or something like that, the excursion has to be much bigger because that load that's coming down is significantly more. And the muscles have to power back up and rebound against that pressure. So again, with the changes that we see here, that load transmission to the pelvis might not be something that is easily mitigated when the muscles now don't have the ability to generate the power and the rebound that we need. And so these are the things that can lead to symptoms like prolapse or incontinence in this phase of life. So the other thing that we also have to address is that the pelvic floor is a group of muscles that works in a system. This is a pressure system. And what's more important about the system is that it's an automated system. So for instance, if you're slipping on some ice and you're about to hit the ground, you're not consciously calculating how much pressure we need in our system so we're not blowing everything right out through our pelvises. You want to be able to put your hands down to break your fall so you don't slip, but on the side, your brain is kind of taking care of the rest, right? But there's a lot of ways to disrupt the system. One of the ways is poor breathing mechanics. We can have surgery that opens up the canister to the outside environment. Building people in that space where there isn't any space for them and how we have to accommodate that. And then how we exit those people out of our bodies is also going to be a challenge to these systems too. So there's a lot of different ways that the system can be challenged. The system can be adaptive to some of those changes, which is why sometimes we might have symptoms that are pre-menopausal years that may be not that significant per se, but then all of a sudden we get to the menopausal years and all of a sudden these symptoms become so much more so much more impactful and dramatic because now the pelvic floor isn't really capable of providing any compensation or support that it may have been providing before. So in short, a pelvic floor only really works as efficiently and optimally as the rest of the system works. So now this brings us to, I'm sure someone's thinking this already or maybe possibly writing it into the chat right now about Kegel exercises. So let's just take a moment and talk about Kegels for a quick second too, because a Kegel exercise is a very honed in, zoomed in approach looking at the pelvic floor muscles as if they work as an isolated entity. They also are an exercise that takes these groups of muscles, pulls them up into a tightening, and then releasing them back down into their resting position. But we've just talked about how these muscles actually do the opposite. They start at rest, accommodate into a lengthening, and then recoil back to the resting position. So essentially, it's the opposite of how these muscles actually work, and also not taking into effect how the rest of the system also works in coordination. So Kegel exercises are a good jumping off point. It can definitely start to do some localized strengthening. But at some point, you do have to take a zoomed out approach and take a look at the efficiencies of the rest of the system as well and address that together. So if you are having symptoms and you've tried the Kegels and you're doing your best and religiously doing them and it's really not making any difference, then it's really important that you go to get your whole system assessed by a person who is specifically trained to be able to assess your pelvic floor in that zoomed in as well as a zoomed out approach, and be able to put together a program that is specifically tuned in to your needs and addressing your symptoms and putting together that program for you. Again, individualized, just like everything else we've talked about.
Yeah, absolutely. And thanks so much for giving us that kind of that trampoline analogy. I think that really is much easier to visualize. This isn't about specifically about pelvic health, physiotherapy or treatment, but when you're experiencing some of these things, there are those folks, just like the ladies that are answering the chat, and Uma and Alana, this is what they do. They know and can help assess and figure out what needs to happen. And taking that even to the next level, the myth about noticing more genital discomfort is unavoidable with aging. I love that this is a myth, but Alana, you're going to have to tell us a little bit more so we can debunk it.
So first of all, I'll just say there's an idea floating around that once you hit perimenopause or menopause, if sex starts to become uncomfortable or any activity in that area starts to become uncomfortable or painful, that's just regular aging. Don't worry about it. There's nothing that can be done. So I'm going to stop that right there because there's nothing further from the truth. Sex should never hurt. It should never be painful. And the great news is there's tons that can be done about it. So first of all, more than half of menopausal women will experience vaginal dryness and discomfort, and only a very small fraction of them will actually go to their doctor with these complaints. So we've been led to believe again that this is just part and parcel of aging. So there's nothing really to be done. So we again know as estrogen levels start to decline, we know that during perimenopause and menopause, the vaginal tissue will change a bit. We know that it gets thinner. There'll be changes to the vagina, but also the vulva, some of the tissues around your vaginal opening, and they can become again thinner, drier, less elastic, like less stretchy, and less well lubricated. So these changes are often, we call it the genitourinary syndrome of menopause. So if you want to look that up, that there's lots of stuff about that in most places. We'll give you some good resources at the end. And so dryness and thinning, as well as the tissues being less elastic, can obviously cause pain with intercourse. There's also changes in pH, like the pH balance and bacterial balance of your vagina is also really disrupted because we lose acidity. And when we lose acidity, that's our body's natural defense system to fight off a lot of harmful bacteria. So you have this dry, thin tissue that, can be abraded really easily, can be broken down really easily, and then the entryway for some bacteria, and then we don't have the right way to fight it off. So that's why a lot of women at this stage will notice an increase in bladder infections or urinary tract infections. We also know that the bottom of the bladder, the nerves there, are really, really sensitive to estrogen. So as we're losing our estrogen, this is where a lot of people will notice that we have less, or we have more urinary urgency. Like we got to go right now, and you got to go, and it's now. And then we'll start going more frequently. You'll have to empty your bladder more frequently. So that's kind of the big part of that. And the great part is there's so much we can do to make women feel comfortable and confident again. So there's vaginal moisturizers and vaginal lubricants. So these are two different things, and people often will get mixed up. So vaginal moisturizers, it's like as we age, everybody knows we're going to moisturize our face and take care of our skin and try and, give it more moisture back as we age, but we don't take care of our skin down there, which we also know is drying out and needs moisture. So vaginal moisturizers are specific for that area, and the ones that especially contain hyaluronic acid seem to work the best. There's many of them over the counter that are available in many different places. The next thing is a vaginal lubricant. So lubricants are different than moisturizers. They do provide moisture, but they're kind of they give you the slip. So they're kind of there to be used during kind of friction activities, so that they're kind of a bit of a barrier and they can protect your skin. So that's the big thing of that. We also know that pelvic floor muscle exercises, and this is our wheelhouse, are also really beneficial. So pelvic floor physio can really help you if you're having, any painful intercourse, any painful penetrative activities at all, if pap smears are really painful, if you have muscle tension, if there's still scars that are bugging people years later after childbirth or after surgery, we can really help you connect with those otherwise hidden muscles. And we actually just had a recent new study show that exercises of the pelvic floor really do promote increased blood flow and relaxation capacity and tissue elasticity in menopausal women. So there are also, I'm going to say right now, a variety of prescription level oral medications, as well as prescription applications to the vagina itself that can be very helpful. These may include hormones or hormone building blocks, but you really want to speak to your doctor or pharmacist who are really knowledgeable about menopause and in this area, just to decide if that's right for you.
Absolutely. And I think you guys can get the sense already that we could talk about this for hours. Unfortunately, we don't have hours to talk about it. And so we put up this slide just to show you some resources. Remember, you're going to get a recording of this. We do apologize that there's a bit of crackle with Uma's voice, but here's some great resources that you can go to. One of the things that I think is really important and can't be emphasized enough really is about your individuality, and what treatment might look like for you would be different than your neighbor, than your friend, than your mom, than your daughter. It's very individualized. I think it's also really important to know that physicians can get as little as 7 hours of training in this area. 7 hours. Like, these ladies have had months on months of training, years and years of experience. 7 hours. So they're not all experts. And if you don't feel like you're being heard and it doesn't feel like you're getting the help you need, keep looking. You know your body best, and we really do want and encourage you to continue to seek out help until you get it. These are myths. If you're feeling like some of these myths you're living, there is help for you, and we want you to kind of reach out to it. I did mention I was going to talk to you a little bit about PC Health, because without PC Health and Lifemark, we wouldn't be here. So thank you so much, PC Health, for this. It is a digital tool with the goal to really increase access for Canadians. It's available as an app. Many of you got here through the PC Health app or at pchealth.ca. It allows that easy access. And once you've logged into the app, there's a significant amount of information that you can get through it. And of course, today we're talking about menopause and perimenopause and that journey. And if you scan this QR code, the PC Health app actually has navigating your menopause journey. So there's a lot of information that you can seek there. And that's our whole goal, is to get information into your hands. And the PC Health app can definitely help you do that. It does also have a great feature of being able to book appointments for physiotherapy, massage therapy, some mental health stuff. Also the ability to manage prescriptions through the digital pharmacy. So we are starting to round things out. One of the questions that we see a lot, and we want to put this slide on for reference, because we're hearing and seeing lots of comments about, okay, how do I get an appointment? Where do I find somebody? So we're going to just leave this up so you can see all the different ways that you can connect with us. But I want to open it up to Alana and Uma. I know we've all been watching the chat. What are some of these common questions that you're seeing that you might take a moment or two to just answer some of the repeated questions that we're seeing?
I can start because I did. Oh, I don't know if I'm frozen now.
No, you're good.
Okay.
No, you're good.
I just wanted to know, I promised somebody that I would go through, they said, like, what should I feel like with a pelvic floor contraction? So I'll show you the cue I like to use. Again, we cannot see if you are doing this correctly. We know that many, many women, when we cue them to do Kegels, and I hate that word because it's just some, I'm very grateful to this gynecologist in the 1940s that they discovered this group of muscles, but that doesn't tell you what to do. And so first of all, these are your private part exercises, and you should not be able to see them from the outside. So if you are, gripping your thighs or gripping your glutes or bouncing up and down, or if somebody sitting next to you looks at you like, what are you doing? You're doing it wrong. So the analogy this is going to sound crazy, but when people come see me, there's a lot of imagine this, because you can't see these muscles. So the analogy that I really like to give is that almost like you have a tissue or a handkerchief. I like to imagine like you've got a square Kleenex. And so you've got this Kleenex, and you're maybe sitting on the Kleenex, because I think most of us are sitting right now. And can you imagine it's a flat Kleenex, and I'm sticking the very center of it, maybe into the beginning of your vaginal opening. And can you imagine you are vacuuming that Kleenex inside you? And as the Kleenex is rising, all the four corners are coming in together, and you want to think of diagonals. So can you feel it lifting and contracting without your bum, without your stomach, without your thighs, any of that coming on. But can you equally importantly feel you putting it back down and relaxing and imagining that all of those four corners are descending again? So that's kind of the very simplified version. Again, your pelvic floor is 11 different muscles in 3 different layers, and people have different strengths and weaknesses, and not everyone leaks for the same reason. So it's very individualized. So just, you know, doing some like rote thing that's meant for everybody sometimes really is not beneficial. So think about that. Lifting the Kleenex.
Lovely. Thanks. Thanks, Alana. I think we all have a visual, and all of us who've been sitting down have been actually trying to do this now. So hopefully, hopefully we catch on. Uma, was there a question that kind of stuck out to you that you saw in the chat?
Well, I did see a couple of questions about leaking, so hopefully we address that as adequately as we could. Can you hear me okay?
Yeah, you break up very, very intermittently.
Oh, sorry. And sorry to everybody if you couldn't hear what I was saying. I apologize. But the main thing that I wanted to say as a take-home message is that it's really important that you are a self-advocator. Not everybody necessarily is going to be open to discussion or be willing to work with you in terms of the options that are out there. Because I did see a couple comments about, you know, he's not wanting to prescribe hormones or what have you, and myself. So you do need to find is willing to work with, willing to discuss and screen you properly for what are the appropriate options that are available to you. And just to reiterate what Andrea you already said is that not everybody necessarily has adequate training in support of perimenopause and menopause. So that's a very important part of sometimes our journey and just self-advocacy.
Yeah, absolutely. And if you missed that, what Uma was saying is that if you're looking for hormones, if you want someone to talk to you about hormones and they're not, or saying no, or it's not appropriate, keep looking. We really do want to be your cheerleaders and keep looking until you find somebody who is listening and taking your concerns to care. You know yourself best. And as being someone who's personally been on this journey, and the changes are subtle to begin with, and you're like, am I experiencing, is there something wrong with my skin? Is there, you know, whatever you're thinking, if there's something wrong, trust in yourself and find those providers that believe you and help you on your journey. It is a journey, folks, and menopause is the only thing that is one cutoff. One day, 12 months after your last period, you're in menopause, but the rest is very much a journey, and it's ups and downs, and we want you to know that we're here for you. We're here with you on that journey, and we also want to just say thank you for joining us tonight from wherever you are. We know we're across the country. You will be getting the recording with a summary notes, and we hope that we have enlightened you a little bit. You've learned one or two different pieces. You get the recording, you can listen to it again, and reach out. Like I said, there's lots of ways you can see on the screen. There's lots of ways to reach out to people who do spend their lives digging into this and understanding it to be able to help you better understand and deal with it so that we can thrive. You know, we can be spending a third of our life, sometimes more, in this menopause phase, and we want to thrive. We want to be thriving women, not just in our childbearing years, but for our entire lives. So again, thank you from Lifemark and PT Health to bring this to you. Thank you for sharing your time with us, and we hope that you found it valuable. We will be sending out the recording as well as asking for your feedback so we can continue to bring things of value to you and continue to help Canadians' journey of being healthy and active folks. Thanks again. Enjoy the rest of your evening, and please keep thriving through perimenopause and menopause.